3 of the Senate budget. We will be hearing from a lot of experts on some very important topics this morning. We will be focusing on health issues covering the Emergency Medical Services Authority, the Office of Statewide Health Planning and Development, and also we'll be looking at the Department of Public Health's budget. We will not be having any vote-only calendar items today, and all items will be opened for discussion, and we will be taking public comment after each item in the discussion today, so thank you very much. Our first speaker and subject matter is Dr. Howard Backer, who is the Director of EMSA. And good morning. We will be asking you, as you know, for an overview of the department this morning. So thank you all for being with us.
Thank you, Madam Chair Corbett and committee members. I'm Dr. Howard Backer, the Director of the Emergency Medical Services Authority, which I'll refer to as the EMS Authority. And this is Sean Trask, the Chief of our Personnel Division. The EMS Authority is one of the departments within California's Health and Human Services Agency, and we are charged with providing statewide coordination and leadership for emergency medical services, largely accomplished through regulations and practice guidelines. The EMS Authority coordinates with 33 local EMS agencies that include 26 single-county agencies and 7 multi-county agencies that provide the day-to-day management of our EMS system. Direct 911 ambulance service is provided by a mixture of public and private entities, including volunteers in rural areas that operate in 338 different zones of the state. Pre-hospital emergency services are one piece of an emergency care network that includes hospital emergency departments and other services that together provide one of our major healthcare safety nets. And the public now takes these services for granted as a guaranteed medical service. The EMS Authority is organized into 3 major functional areas. First, our EMS Systems Division reviews and approves EMS plans to ensure that local EMS systems are organized to provide quality care and to ensure compliance with statute, regulations, and standards. They also approve exclusive operating areas for EMS patient transport according to legislative intent of our statute. The EMS Authority provides statewide coordination and leadership for the trauma care system, which are designed and managed by local EMS agencies. We're now developing other regional systems of specialized care, including stroke and cardiac or heart attack. The EMS Authority also has responsibility for coordination of pediatric emergency system that ensures that acutely ill and injured children have access to comprehensive emergency and critical care services that can manage their special needs. And finally, this division oversees the operation of California's statewide poison control system, which receives about 300,000 calls per year through a toll-free telephone number and provides services free of charge to the public as well as to medical providers. One of our current EMS system challenges and initiatives is to oversee the transformation of EMS providers and agencies to an electronic patient care record that can be aggregated and analyzed at the local and state levels to evaluate the EMS system and drive quality improvement of patient care. Second, our Personnel Division operates a state paramedic licensure program. It conducts disciplinary investigations of paramedics, sets scope of practice and medical training standards for EMS and public safety personnel. In California, there are now 60,000 certified EMTs, 20,000 licensed paramedics. They respond to more than 3 million calls for service annually using 3,600 ground ambulances and 50 air ambulances. They generally take the ill or injured to one of 310 acute care emergency departments that may be part of our 76 designated trauma care centers. One new initiative, again, involves an application to the Office of Statewide Planning and Development in their Health Workforce Pilot Program to test and evaluate the use of paramedics in expanded mobile healthcare roles to fill some of the gaps in local healthcare systems. Finally, the EMS Authority is a designated agency for coordinating California's medical response to disasters, in which we partner with the Department of Public Health to lead our state's public health and medical emergency function in support of local jurisdictions. We work with local and federal partners to plan for the medical impact of disasters and major events, from earthquakes to air crashes, and from influenza pandemics to drought. EMSA has developed a tiered response to disasters, the first tier consisting of ambulance strike teams that are dispersed in local jurisdictions and that would establish a field triage and treatment station for multi-casualty incidences within 1 to 2 hours. The second tier is California medical assistance teams that are comprised of 5 to 40 members that can deploy within 12 hours, set up in either a tent or any standing facility, and begin providing medical care. Additional personnel can be pulled from our disaster healthcare volunteer registry, which currently contains over 20,000 licensed personnel in all different disciplines, including the locally organized Medical Reserve Corps. And the third tier is our mobile field hospital program. The 3 200-bed mobile field hospitals and teams to staff them provide general acute care hospital capability and may serve to replace or supplement a hospital. Each mobile hospital includes an emergency department, surgical suite, intensive care, and treatment wards, and includes lab, x-ray, and pharmacy. One of the most concerning impact of recent budget shortfalls was the loss of funding to maintain these mobile field hospital assets. And EMSA has now consolidated the assets in a single part of the state and is focusing on maintaining the ability to rapidly deploy at least one of the field hospitals, with the others in a delayed deployment mode. As far as our current budget, the governor's proposed budget for 2014-15 includes expenditure authority in the amount of $28.4 million and 65.2 permanent positions, so we are a very small department. Of this amount, $13.1 million is delegated for state operations and $15.3 is local assistance. The budget adjustment we want to discuss today is the epinephrine auto-injector training program. SB 669, as chaptered, and authorizes off-duty pre-hospital emergency medical care personnel and lay rescuers to obtain and use an epinephrine auto-injector, so-called EpiPen, which looks like this. This is still in the case. Utilize it in emergency situations after receiving training and certification. The bill requires EMS authority to approve authorized training programs and providers, and to establish and approve minimum standards for training and certification on the use and administration of these epi auto-injectors as specified by the bill. So the EMS authority is requesting one 2-year limited term position and a $135,000 specialized first aid training approval fund beginning in July of 2014 to address the new workload associated with the development and implementation of the auto-injector program. SB 669 permits the EMS authority to impose a reasonable fee on training providers for the review, approval, and certification of the programs, but we don't expect to generate revenue from the program until July of 2015. Due to this delay in revenue, the EMS authority is requesting a $135,000 internal loan from our Emergency Medical Services Personnel Fund for the initial program startup costs. We estimate that the process of implementing this program will take 24 months, including convening a task force, agreeing on training standards, producing draft regulations, complete the rulemaking process, and developing program guidelines and procedures. And finally, I was asked to comment on funding reductions. We've been notified by our federal partners that one of our 2 federal preparedness grants, the Hospital Preparedness Grant, may or will decline by 30 to 40% in the 2014-15 fiscal year. We're awaiting issuance of the grant award to determine the final state allocations. The EMS Authority and Department of Public Health have assessed priorities for this grant previously with the anticipation that it would be reduced about 30%, and we are agreed on the following guiding principles: that no new activities would be funded, the reductions would be taken in both state and local funding allocations, that Public Health and EMS Authority would consolidate activities between us that were conducted by both departments, we would eliminate redundancies between state and local levels, and that funding for functions that have moved from development to maintenance would be reduced. However, the impact would be greatest to the EMS Authority, who relies mostly on this funding. Many programs were cross-funded with public health and hospital preparedness funding, so Department of Public Health would also, though, be impacted. A few of the specific impacts on the EMS Authority and our preparedness program is that we would lose about 10% of our disaster medical staff, which is really our most important resource. Trained staff is needed to manage emergency operations and implement response plans. We would not be able to sustain the investment in the medical surge assets, such as our mobile field hospitals, even in their mothballed status. We would seriously degrade our planning efforts and our exercise functions for our existing plans. Plans that are not exercised are simply binders on a shelf with insufficient knowledge of their content and their weaknesses. Thank you.
Thank you very much for that presentation. Just want to ask first, are there any comments by the LAO or DOF on this presentation? Okay, good, everybody's fine. Let me just first comment. I think that your presentation is very important in that it draws a light to very important services that people don't think about every day, except in case of an emergency when they really do need the help that is provided through your services, and that we ensure that we have well-trained individuals, which you oversee as well. So I just wanted to ask, what is, this is obviously a very, very important service. If the public wants more information about your department, what is the best way for them to really understand, besides knowing that when a paramedic happens to be there to care for someone, and that's very important. So what other ways do you give the public the way to access the information about your department?
Well, information in our department is there's a fairly extensive information on our website, all of our guidelines, everything that we do and everything that we produce, all our regulations are there. And the interested parts of the public members will go to there if they have a specific issue. But in terms of, I kind of got the sense you were talking about use of 911 services.
Well, 911 services, but just in general, the types of programs that fall within your department, more knowledge about the emergency services, the field hospitals, those sorts of things. Obviously, the individuals who are involved in providing those services are probably quite knowledgeable about what's available, but just the general public. As I was sitting here listening to your presentation, just dawned on me that people probably aren't so aware that there is an EMSA department, and having more knowledge about what you do, you're sort of, unsung heroes in a way. Again, it's one of those services that you don't think about till you need it. So I just was thinking it might be an opportunity to give the public a better overview of what you do.
No, I appreciate that, but I think from the public standpoint, they mostly see their local services. So they see their local fire agencies and private ambulance providers because they see them on the streets and they see them responding in their neighborhood. They work with their local EMS agency, and unfortunately, as many state agencies, we're seen as the kind of, we're just the state government that regulates, and so they don't see our direct involvement in their day-to-day services.
That's my point.
Right. Although in disaster services may be the most direct, but we do actually create programs that go down to the public, and we do have extensive information on the website, but someone has to be motivated to go looking for it.
Okay, so you have a good...
Although I would love to find a way to promote our activities and more knowledge.
I think you should do more of that. And then I just have a question about the EpiPen. It's a brand new program. We, as legislators, we were very familiar with this. It was a well-debated topic here in the Capitol. And I see your plan of rolling out the program. Can you tell us a little bit more about any concerns you may have about making sure that this program has the resources it needs to be successful?
Well, I'll let Sean speak here, but our challenge here is we have no idea how popular this program will be. I mean, we have parents who have allergic children already have access to EpiPens. So this is really for the members of the public who just want to be prepared, or people who do have responsibility for members of the public, like guides and park rangers, things like that, can now get easier access. But we really don't know what kind of response we're going to get. Would you have further comments on that, Sean?
Only that we'd be establishing the training standards, and we'd be able to track how many training programs actually teach EpiPen use, but it would be difficult for us to track the utilization, because the public can get this training and we're not sure how much utilization is going to occur.
One of the shortcomings of the legislation was that there's no way to we don't have any reporting, so we don't know how often these are used and whether they're appropriately used.
All right, thank you very much. Senator Monti.
I want to thank you also for your testimony and the work of the department. I had just a couple of questions on the mobile field hospital. I know that was targeted for total elimination in our dark budget days of a few years ago, and I understand that there's been some federal support to help maintain that readiness. You said there's 3 mobile field hospital units all being maintained in one area now. Can you tell us where that is?
Yes, it's in the Sacramento area. Originally, the program had them dispersed, one in the Bay Area, one in Southern California,
Right.
and one in the Sacramento area. And in order to sustain with the loss of funding to sustain the program, first we pulled them in so we didn't have to pay the extra warehouse space. We've actually got some donated space at FoodLink, and then we have one of them in a warehouse that we maintain. But the recent sustaining of the program was done through using HPP funding. And with the HPP funding decreasing a third or more, we'll be hard-pressed to keep that prioritization without some other source of funding.
So under the current situation, if there were an event in Los Angeles or San Diego, how long would it take to mobilize and set up one of the field hospitals?
We would truck them down there. So, that can be done, or fly them if necessary. So that could be done within a day. We also lost our vendor who was responsible for all the setup and wraparound services, so we have to do just-in-time training. So we're still trying to stick with the goal of at least getting the first structures up in 72 hours so we can begin providing emergency level care and then adding modules. But I think that's a stretch, and we'll be aiming for between 3 and 5 days to be operational on the ground, and then we can keep adding modules. That's for one of the hospitals. The other two would take longer to.
Yeah. Well, my concern, if there were a major earthquake or other disaster incident in Southern California or any part in the state, is the lag time. Why have you explored deployment in other parts of the state in space that might be a National Guard facility or something that there wouldn't be a high cost attached to storage and preparedness?
Yes, sir. We've spent the last 2 years looking for public-private partnerships or public-public partnerships. Everyone from National Guard, DoD, HHS, large corporations. We were, actually, to my surprise, we were coming up short, and we did not get any significant offers for the warehouse space we would need down there or elsewhere in the state.
And are you pursuing efforts to find other locations or partnerships?
I would follow up on any leads, and I still take every opportunity to let it be known to any groups that are disaster focused that we have this need.
And as part of your regular activities, you participate in disaster preparedness drills or exercises?
Yes, sir. Last year we had a large one. Our last really large functional exercise was down at Moffett Field in the Bay Area with an earthquake scenario. And we set up not the hospital, but tents, and deployed our medical teams and worked with National Guard and many other teams to exercise our assets and our medical personnel resources as well.
And I understand the financial constraints that make that consolidation necessary, but just seems from a preparedness point of view, having those emergency field hospitals deployed north, central, and south would save time and potentially lives. So I would encourage you to continue to pursue options.
I have to agree with you, and that's why I brought it up here.
Thank you.
May I ask you, just following along those same lines, I have the same concerns. Have you been working with local law enforcement? Are there any large departments, sheriff's departments in the state that might be willing to partner with you? Is that an avenue you have explored in the past?
We have a statutory commission, and we do most of our work, since we're a small department, through stakeholder work groups, and law enforcement, first responders, law enforcement, fire are some of our major stakeholders. So representatives from all the major law enforcement groups are part of those groups, and they have heard me discuss this many times.
But no takers so far.
No takers.
All right. Well, thank you for that. And then I have one last question. The EpiPen program being a brand new program, you might not have this information yet, but since this is a training that's going to be made available to the public, do you have any information for us as to how you're going to publicize that to ensure that people know this opportunity is available?
That would primarily be through our website and perhaps the local EMS agencies, the 33 local EMS agencies throughout the state, as well as our stakeholder groups that are made up of our commission and other groups that we work with. We've received some interest from other allergy groups who want to participate in this development process. So we would certainly be working with them to get the word out.
Also, remember, we don't provide the training, we approve the training programs, so the actual training providers, it's in their interest to advertise and let people know that this is available.
Do you ever partner with legislative offices? I mean, I always like to bring this up because each of us has a district office where we're very keyed in with all of the various different community groups. And so you have, places around the state that could help provide information for your services, and all departments, of course, can do this. Have you ever partnered, like, through the legislative district office network?
I'm not aware of using that avenue. I didn't know if that would be, frowned on or approved of by the administration going that route. But
might be a good thing to explore.
Thank you very much.
All right. Thank you very much, too, and thank you very much for your presentation. This is an action item, and I do not see any. Oh, yes, before we do that, is there any public comment on this item? If there is, please come forward. All right. Yes, please come forward. Where does they speak from there? Yes. Welcome.
Thank you. My name is Carla Fitzgerald Williams, and I have a 17-year-old son that has the life-threatening peanut allergy. I know the EpiPens very, very well. The one thing is the parents do have EpiPens in their possessions. When those children are away from home, they may or may not have remembered to have taken the EpiPen with them. One of our greatest fears for him as he's approached the teen years is that he will walk away from home. And Dr. Shear in New York, who's a very prominent allergist, told me probably 13, 14 years ago when I met with him that the teen years were in fact the years that I needed to fear for our son. He was absolutely correct. It's even worse with boys than with girls because they don't carry bags with them. Girls can slip them in their purses. Okay? So if that EpiPen, I live in Los Angeles, if our emergency teams were equipped with that EpiPen, it might in fact save my child's life and the lives of many other children. Okay. Sometimes the pens also expire in the homes. The pharmacies are not always on top of dispensing medication with long shelf life. Sometimes they will, in fact, attempt to give you an EpiPen that has a 3-month shelf life. That doesn't help you, okay? The EMT will have current medication. They will be trained to use them. You might also be able to identify groups to help you get the word out through the pharmacist, because when they dispense them, if it's legally possible, that would be a time to slip something in there that says, here, your local EMT is able to dispense this. FAN, the Food Allergy and Anaphylaxis Network, would be of help. And the key allergists. The allergists in the communities would also be interested in outreach. So I would implore you to please take a look at doing that. It's life-saving. It's a couple of minutes to death for this impacted community.
Thank you very much for your suggestions. Any other public comments? All right.
Thank you for your time.
Thank you very much. A motion's in order.
So moved.
So moved by Senator Monning, and I'm in support as well, so we adopt that. Thank you very much. Thank you very much. We're going to the next item on the agenda. We'd like to welcome Bob David, Director of OSHPD, to come forward. Good morning. Good to see you all.
Thank you.
And of course, we'll be asking you also for a brief overview of OSHPD's programs and budget today. Thank you.
Thank you, Senators. I'm Robert David, and I'm the Director of the Office of Statewide Health Planning and Development. I'm joined today on my left, Lupe Alonso Diaz, who runs our Healthcare and Workforce Division, and Ron Spingarn, who runs our Healthcare Information Division, and they'll be presenting our budget change proposals a little after my presentation. The Office of Statewide Health Planning and Development advances Californians' access to safe, quality health care environments by focusing in 3 primary areas: health workforce development, healthcare data collection and reporting, and healthcare construction and financing. OSHPD has 2 areas at the department focusing on health workforce development: the Health Workforce Development Division and the Health Professions Education Foundation. Our health workforce development programs seek to increase access to health care for underserved communities and populations by ensuring that California has a diverse and culturally and linguistically competent health workforce. We focus on hard-to-recruit and retain health professions. We increase the geographic distribution of California's health workforce, and we explore new service delivery models. Our Healthcare Information Division serves as a healthcare data collection and reporting hub. We collect healthcare data from California's licensed health facilities. We collect patient-level utilization and financial data. We make that data available to the public, researchers, policymakers, and others, and we prepare analyses and reports on healthcare quality and outcomes and other related health topics. OSHPD's Facilities Development Division serves as the building official for California's hospitals and skilled nursing facilities. We administer the Seismic Safety Program focused on strengthening California's hospital buildings so they can remain operational in the event of an earthquake. Through our Cal Mortgage program, we provide health facility construction loan insurance to hospitals and other health facilities like St. Rose Hospital in Hayward, which I know we worked on together a few years ago. California's nonprofit health facilities can gain access to low-cost financing for their capital construction needs through Cal Mortgage. A quick budget overview of the department. Our 2014-15 proposed budget is $145.7 million and 479.6 positions. OSHPD, as you might note, is funded primarily by special funds, many of which are fee-supported. We have a small amount of federal funding, $1.4 million in 14-15, to support our healthcare workforce programs. This department only has $74,000 in general fund support. Beginning this year, we've also received a 3-year, $52 million grant from the California Endowment. to provide additional funding for OSHPD's Song Brown program to train health professionals to provide service in underserved areas, and to provide additional scholarships and loan repayment programs via our Health Professions Education Foundation to health professionals who will practice in medically underserved areas. We have 4 budget proposals for your consideration today in the areas of health workforce development and data collection. I thank you.